Okay, let's talk about microcytic anemias. Look for red blood cells with a mean corpuscular volume less than 80. All of these, whether it's a thalassemia, anemia of chronic disease, iron deficiency, lead poisoning, or sideroblastic anemia, most of these are kind of united in the sense that they really just stem from a failure to produce hemoglobin. Red blood cells have just really bags of hemoglobin. They have 2 alpha chains, 2 beta chains, and a couple of heme groups, which is a protoporphyrin ring containing iron. So we're going to get into all of these. Less hemoglobin means that it's hypochromic. What gives red its red color is the hemoglobin and how it interacts with light. So if you have less hemoglobin, you're going to have hypochromicity. So this is going to be a microcytic anemia, and this is going to be just a normal, healthy one over here. Additionally, to keep the hemoglobin to volume ratio normal, your bone marrow cranks out smaller than normal red blood cells. Or at least, we can put an asterisk because not all the time, but typically that's what it tries to do. So you can produce less hemoglobin, and so the solution is have smaller red blood cells, and then it'll kind of fit more or less. So the ways that we can get this is we can have defects in the globin production. This will be the thalassemias, less iron. This could just be an iron deficiency or defective heme production. You could have an enzyme deficiency, and you could have lead poisoning. Let's start with the thalassemias. So like I said, your hemoglobin is 2 alpha chains and 2 beta chains. Thalassemia is probably going to be most significant in, people of Greek descent, Italian descent, people in the Mediterranean. It is a protective effect similar to sickle cell against malaria and plasmodium. And we have 3 main types for adults: hemoglobin A, A2, and F. Notice that alphas are in all of these. So alphas is arguably the most important then, and it's the partner then that determines the type, right? So like A is going to be because of the beta. This is going to be, A2 is going to be because of the delta. And then the fetal is going to be because of the gamma. We'll ignore this one. And then the abnormal ones, the H and the BARTs. This will be triple thalassemia alpha, and this will be quadruple thalassemia alpha. I'll talk more about this in a hot second. So, while the alpha chain might seem more important, I guess you could consider it more robust. Maybe this is debatable, but because we have 4 copies of it rather than 2 copies of the beta globin genes. So you can, if you lose one beta globin gene, like now you only have 50% beta globin production, but you have 4 alpha globin genes. So you could arguably lose one and you could still be okay. So 4 alpha globin, 2 beta genes. If you have a defect in an alpha gene, it's a deletion. So missing alpha gene is all or nothing. On the other hand, though, the beta genes, they very rarely get deleted. It's usually just a mutation. So it could be a variable effect then, right? Maybe it's just less transcription. Maybe the protein is made, but it's just a little bit less functional. Maybe it's not functional at all, right? It depends. So we have the B plus or B1, which is reduced functional capacity for that particular gene, and then just B naught, where either we're not having any transcription or the gene, like the protein itself, just sucks. For the alphas, again, note that you have 4, so you could have 1 defective, you could have 2 defective, you could have 3 defective, or you could have all 4 defective. Notice in the 2 defective case, it could be trans mutation, meaning that we're diploid on the mommy version, on the daddy version, you have a defects. Or it could be cis, meaning both come from the mommy version or both come from the daddy version. Interestingly, people of African descent typically have if they're thalassemia minor, meaning they have 2 defective alpha genes, they're usually in different chromosomes. They're a homologous pair. But for people of Asian descent, they're often on the same one, which is interesting. And you should know. Alpha versus beta. All right, let's just get into the details. Alpha thalassemia, 1 deletion. Sometimes this is called minima, no symptoms. 2 deletions, mild anemia. Sometimes this is called minor or trait. Like we just said, Asians would be cis on the same chromosome, while the Africans, people of African descent might have 1 on 1 chromosome and 1 on the other chromosome. If you have 3 deletions, again, alpha is going to be complete deletions. You will have severe anemia. This is where you accumulate the H, sometimes it's called H disease, and this because you have the hemoglobin H, which is really just a beta tetramer. If you think about it, this kind of makes sense, right? The main type of hemoglobin, 97% of your hemoglobin is hemoglobin A, which is supposed to be alpha and beta. But you have 25% of normal alpha production, meaning there's just way more betas than normal. So the betas are just going to pair together, and sometimes they make these tetramers, which we call hemoglobin H. This is really bad for the red blood cells, and they're basically they're going to explode on their own, or the spleen's going to notice that they're abnormal, and hemolysis will ensue. LDH increases, the spleen tries to eat them up, so you get splenomegaly. And when they spill their guts into the bloodstream, the heme gets converted to bilirubin, so the bilirubin levels go up. You could get things like jaundice. Now, if you have 4 deletions, this is incompatible with life. Hydrops fetalis, massive edema, and heart failure for the baby. You have something called now the Bart's tetramer. So the hemoglobin H, you could be a kid or an adult and live with this. You might be sick. You might need transfusions all the time. But you have this beta tetramer. Why do we have the gamma tetramer here? It's because the gamma is produced very early on when you're 1 or 2 months old, and it eventually goes away. But so these gamma globin genes will accumulate. You probably won't even get to the point where you could form the hemoglobin H beta tetramer, or at least not a significant amount. So if that made sense to you, great. If not, it's not a big deal. Hemoglobin H for 3 deletions, the gamma for the Bart's tetramer for the 4 deletions. All right, beta thalassemia. 1 deletions, minor. 2 deletions, and I shouldn't say deletions, I should say mutations. 2 mutations would be a major anemia, sometimes called Cooley's anemia. So your body is desperately trying to crank out red blood cells that are effective. So it's doing something called extramedullary hematopoiesis. And think about this. Medulla is the bone marrow, and then hematopoiesis is the making of blood cells. So effectively, your body's trying to make red blood cells outside of the bone marrow. There's a bone marrow expansion during early development and embryogenesis that causes skeletal deformities, and not the nicest phrase, but that it's known as I guess the face kind of looks like a chipmunk face, so chipmunk faces, and sometimes they say a crew cut appearance for the skull on an X-ray. And so this is bone marrow expansion due to excess erythropoietin, because there's no negative feedback because you don't have proper red blood cells being formed. Sometimes the extramedullary hematopoiesis will be present in the skin, so your skin will start trying to make red blood cells. And then your spleen and your liver start to try to make red blood cells. And nobody's as good as making your red blood cells as your bone marrow, so you get nucleated red blood cells sometimes when it's extramedullary. Often, whether it's a minor anemia or a major anemia for betas, you won't see it for 6 months, because you do have hemoglobin F for the fetal hemoglobin for 6 months of your life from mom until the production stops and these hemoglobin proteins start to decay. And this isn't affected by beta because the hemoglobin F is 2 alpha genes and 2 gamma genes. For the again, we're still just specifically in the major. I would note that they have crazy variety of red blood cells on a histological smear. Anisocytosis, which is a variable red blood cell width distribution. Poikilocytosis, the shapes are going to be all funky. Basophilic stippling, they're going to have RNA, and then target cells. We'll see all of these, and we'll go into detail. So anisocytosis, just the red blood cell width distribution is going to be all over the place. So you can't really see it so much right here. Let's just imagine this was a little thinner and this was a little wider. So basically, there's just more variability for the beta thalassemia major as opposed to the normal one. So yeah, they can be all sorts of shapes and sizes. Let's just focus on this. Basophilic stippling, we have these RNA fragments all over the place. Not just fragments, but they will precipitate and form these collections, which are identifiable on histological analysis. And then we get these target cells. Target cells come from like a screwed up surface area to volume ratio. So you can have a defective surface area to volume ratio with beta thalassemia major. You can also have it in situations where so here we have a decreased cell volume because we're microcytic anemia. You could also have it if you had, instead of the volume being screwed up, maybe the surface area is screwed up. The cell membrane is going to be dysfunctional if you have a liver disease due to defects and alterations in cholesterol metabolism. All right, so Yeah, like kind of be familiar with this. Maybe let's just focus on this one on the right here. So this would be a normal person. They have a little bit of A2, a teeny amount of F, and then mostly like 97% hemoglobin A. But if you're thalassemia B minor, notice that we have a lot less A because A is going to be, two alphas and two betas, and we don't have as many betas. So what we have is a little bit more of the A2 and a little bit more of the F. Now, if we go all the way to thalassemia beta major, you have almost no beta. So the hemoglobin A is almost invisible. The hemoglobin F and the hemoglobin A2 goes way up. Now, if we go to triple A, so thalassemia alpha, but it's three deletions, and it is deletions in the alpha versus the beta. This is where you have the H, which is going to be the beta tetramer. So here's our beta tetramer over there, hemoglobin H. Again, if it was a four deletions, it would be the gamma tetramer, BARTs. And then over here we have hemoglobin S. Well, this has to be sickle cell, which we'll talk about later. Okay, so thalassemia is the first way. We just don't have good, we're not making appropriate globin genes, and therefore we can't make hemoglobin. If you can't make hemoglobin, you make smaller red blood cells. Alternatively, we could have not enough iron. And remember that iron is in heme, and you need heme to make hemoglobin, so it's going to be kind of the same deal here. So how do we get iron? Sometimes we get some free iron, but most of the iron that we obtain is through meat in the form of heme. So vegetarians and vegans would be more predisposed to be iron deficient than somebody who eats a steak for every meal. I'm not advocating like a pro-meat diet at all, but just that is how it is. It is difficult to excrete iron unless you have heavy menstrual flows, or particularly important is colorectal cancer. If you have colorectal cancer, you will have blood in your stool. Often it's cryptic, meaning sometimes it's microscopic. You don't even know you're losing blood, but you're actually losing a ton of blood every bowel movement. And over time, there is the equilibrium is thrown off. You're excreting much more than you're taking in. And over the course of months or years, you become severely iron deficient. Colorectal cancer is particularly slow growing as far as cancers grow. And if you get blood transfusions, I mentioned this before, but you might throw off this equilibrium in the other direction. You might have excess iron in this case. So two iron-related proteins that we should know are two main ones. Ferritin. Ferritin stores iron. It stores this in macrophages, which is going to be in the bone and the liver. And now if you're iron deficient, well, then your stores are going to go down. So this is going to go down in that case. That kind of makes sense. You have less stores in the macrophages. We have a picture a little bit over here. Here's our bone marrow. Here is our macrophages storing it in the form of ferritin. Also in the liver, storing it. We also have a protein called ferroportin, which is going to transport it out of the cell and into the cell. Also, it's going to help us absorb through the GI tract as well. Our other protein is transferrin. So I like to think of transferrin as, imagine that, your blood sugar should be around like 100. And if the blood sugar goes down, you have glucagon, which raises it. And if the blood sugar goes up, you just had 8 brownies, then you're going to have insulin that's going to bring the sugar levels down. It's kind of a similar thing with the iron levels. We want a nice homeostasis for the iron concentration in our blood. So if we're iron deficient, iron levels in our blood go down. Transferrin is going to kind of work like glucagon. It's going to raise, in the same way that glucagon raises the blood sugar, this is going to raise the iron levels in the blood. Now, I guess the difference is glucagon doesn't actually carry sugar. This raises the iron levels of blood. It also then transfers it through the blood as well. So it's not completely analogous. I would just know that TIBC and transferrin are more or less the same thing. Total iron binding capacity. TIBC is really just transferrin for our purposes. And so if we're iron deficient, that means that the iron levels in our blood went down. We want to raise them. So the transferrin levels is going to raise the iron in our blood. Again, think of it like blood sugar. I think it becomes a lot easier to conceptualize. And now there's something called the percent saturation, which is really just the transferrin levels over the serum iron levels. If you are iron deficient, so here's our protoporphyrin ring. Notice that we have no iron here. So and the only difference between heme and that is that you have the iron. So you know what? If you're iron deficient, then this is going to go up and this is going to go down. So sometimes they'll say that your free erythrocyte protoporphyrin levels are up, and that just means that you're iron deficient, or that's one possibility. So how do you become iron deficient? So like I said, maybe you're a vegetarian, you're vegan, and you're not taking supplements, and you're, I don't know what else, whatever type of kidney bean or something has lots of iron, you're not eating that. So that might make you iron deficient. Maybe you have a bad diet and you're an alcoholic or something, and so that might cause a malnutrition. Probably more likely is malabsorption. So maybe you have celiac disease or some other duodenal issue, and that's going to cause malabsorption. If you're on a proton pump inhibitor, this is going to push iron from the Fe2 plus state into the Fe3 plus state, and the Fe3 plus state has a harder time being absorbed. So if you have lots of stomach ulcers, you take PPI, that might cause you to become iron deficient. And then the iron demand goes up in pregnant women. And so maybe you're just carrying on business as usual, eating what you normally do, exercising like you normally do, and yet the iron demand's gone up and you have not raised your burger intake or whatever, and so you might become iron deficient in that case as well. Two other scenarios where you might become iron deficient: hookworms, scary monster. These will go ahead and just scavenge a lot of your iron. It's one of the many horrible things they'll do inside of you. And then there's a rare syndrome called Plummer-Vinson syndrome, which you'll see a lot. You'll see a bit more in the GI thing in I guess like 9 months or so. Look out for a triad. So one of these, the relevant one is that you become iron deficient. Esophageal web. So this is a healthy esophagus. And this right here is just this little thing that's kind of jutting out. That is an esophageal web. And you have a hard time swallowing as well. So Plummer-Vinson syndrome it could also lead to iron microcytic anemia. So early on, so here's our microcytic and here's our normocytic iron deficiency. So early, it's normocytic, normal size, and then later it becomes microcytic. So if they don't give you the context, I would probably just go ahead and say it's microcytic. But early on, you produce less red blood cells with, you produce less red blood cells, but they're the normal size. Eventually, you start producing less red blood cells, and they're smaller as well. So the RDW is up. So a kind of an anisocytosis. We have this, our width is up. So we saw this with beta thalassemia, also known as Cooley's anemia as well. So anemia of chronic disease. If you have an infection or if you have an autoimmune disease. So if you have an autoimmune disease, your body kind of thinks maybe that it has an infection. You're in a chronic inflammatory state. And so you're making a lot of cytokines. One that's relevant is hepcidin. And so a kind of interesting evolutionary defense mechanism is that a lot of pathogens want to come in, and it's really important that they get iron. So one of the first things they'll do if they're trying to replicate inside of you is they'll steal a lot of your iron. So as a defense mechanism, your body kind of salts the earth a little bit, and it's going to the hepcidin is going to inhibit ferroportin. And if you remember from the previous slides, ferroportin's job is to transfer iron across cell membranes and also to absorb it from the GI tract. So you're going to get less iron overall. You're basically hiding it from the, let's say, the bacteria or the parasite to starve it of iron so that it might die. And it's the same explanation as before, the fact that we see this as both a normocytic, here's our anemia of chronic disease, and it's over here as well. So initially, you might produce less red blood cells of normal size, and then later there'll be less red blood cells, but they'll also just have less hemoglobin, and therefore they'll be smaller. Lead poisoning. So just look for them saying, hey, somebody was doing construction in an 80-year-old house, or some kid was licking the paint off their 80-year-old house. That's lead poisoning. That's going to come up in a vignette. Lead paint. So specifically, it will inhibit either ALA dehydratase or ferrochelatase. Also keep in mind that these steps are in the mitochondria and these steps are in the cytosol. So it doesn't inhibit it 100%. So you very well might have a buildup of ALA. So these levels might go up a little bit. Same thing with this. You're going to inhibit this, and therefore you might get a little bit of this to go up. So you might have higher levels of protoporphyrin, higher levels of ALA, and of course you're having a hard time complexing your iron with the protoporphyrin, so your iron levels might be a little bit higher as well. Things to look out for lead poisoning: abdominal pain, lead lines. So this can be called burden lines in the gums. Shown here, you can kind of see this lead deposits. And then in the bone metaphyses on x-rays, you shouldn't have this little white line here. That's lead accumulating at the metaphyses. Peripheral neuropathy, neurological defects in developing kids is particularly important. So if you have a 5-year-old kid who's having trouble talking or something, they are not, you think of the Piaget stages in the MCAT psych section. These kids are not reaching their milestones. It might be that their brain development is a little bit screwed up because of the lead that they're consuming. So as a therapy, you can chelate lead with things like EDTA, dimercaprol, and Sossamer. So for basophilic stippling, so we saw this earlier in severe beta thalassemia. This is where you have the RNA remnants. So it turns out lead also inhibits this enzyme, which breaks down RNA. Therefore, you're going to have more RNA, and it's going to concentrate itself and form these little insoluble granules, basophilic stippling. Additionally, like we said, you're going to have, you can't complex the protoporphyrin with the iron to make heme, so the iron levels are going to go up, and the iron is stored in these little granules shown here. I would know if they say something is a Prussian blue stain positive, this is specifically looking for iron. You can have sideroblasts in the bone marrow, but if you have sideroblasts pushed out in the red blood or into the systemic circulation, that is a sign that there is maybe lead poisoning or something wrong with your heme synthesis pathway. So these are sideroblasts, and this is sometimes termed as sideroblastic anemia. So one cause here, so like we said that, sometimes these are nucleated red blood cells, but they have these iron granules, and outside of the bone marrow, this would be abnormal. So not enough protoporphyrin to pair with the iron. So good, we talked about that. And we said that lead poisoning makes sense. Now, what are other causes? Vitamin B6 deficiency. So maybe you're not getting enough vitamin B6 in your diet, but it's more likely that you're on like a tuberculosis medicine, like isoniazid, and this is going to inhibit and lower the levels of B6. Notice that B6 is an important cofactor for this very first step. So if you have isoniazid, you have lower B6, and therefore you can't do this first step, and that might mean that you're going to have less heme production. Alternatively, alcohol is a mitochondrial poison, and we said that all of this is in the mitochondria, and so this might also screw up this first and last step, and again, you're going to have lower heme production. You could also have ALA synthase deficiency, which is an X-linked syndrome, and so specifically this is down, and again, same thing. This would cause heme production to go down, which might cause sideroblastic anemia. Okay, iron study. So, let's just think about iron deficiency over here. Well, you know what? It's friggin' in the name. So your serum iron levels, they're going to go down. They're low. Why? Because they're actually low. And if the iron levels are low, then you know what? You're storing less iron. So that sort of makes sense. Now remember, it's like glucose in the blood. Your iron levels in the blood are going down. Your TIBC, which is just your transferrin, its job is to raise your iron levels. It also transports it, but just think of it as it's more important. It's easier just to think it's trying to raise the iron levels. So it's trying to raise the iron levels, so this goes up. Now the percent saturation, remember that this is the iron over the TIBC, and the iron went down and the TIBC went up, so this is going to go double down, hence the double arrows. Anemia, chronic disease. So this is low iron levels, but remember, it's not actually low. The serum level is low. That's because we're hiding it from the the monsters, the bacteria, whatever pathogen. And again, it might not actually be a pathogen. It might be that you have an autoimmune disease and you're in a chronic inflammatory state, and so the hepcidin is it's quote unquote like your body thinks that it's under attack, and so it's nevertheless hiding it. And so if it's hiding it, where is it hiding it? It's storing in those macrophages in the bone marrow and the liver, so the ferritin level goes up, and then this is going to go down as a result. And then sideroblastic anemia, you can't use it. You cannot complex it with the protoporphyrin to make heme, so it's going to go up. The ferritin levels are going to go up. Why? Because you have more, so you've got to store more of it. And then the TIBC, this one's a little tricky. I don't think this one's important. It's the same. Sometimes people say that it might be a little bit lower, and that's because it's trying to, I'm not even really sure. Let's just say same. I don't think this one's particularly important, so I'm going to skip over that. All right, so this is a little decision tree. If we have a low heme levels, it's either lead poisoning or sideroblastic anemia due to, maybe like X-linked ALA synthase deficiency. If you have, and again, this hypochromic is also going to be very telling. Low iron, maybe you just have low iron. Maybe you have a colorectal GI bleed. Maybe you have anemia of chronic disease because you have an autoimmune condition or you have an infection. If we see that there's something wrong with your beta thing, maybe you have a thalassemia. Do you have hemoglobin H? If so, you have 3 defective alpha genes. Do you have hemoglobin BART? If so, you have 4 defective alpha genes. Do you have more A2? Do you have more F? This might be a beta thalassemia. Do you have the chipmunk facies? Do you have, what is the red blood cell distribution width like? Do you have basophilic stippling? These are all things that you're going to go ahead and evaluate when you're, making your decision. Normocytic.